Thank you very much for asking me to speak at your meeting. I'm very grateful to Sobi and the organisers for asking me. I'm Drew Provan. I'm a haematologist at the Royal London Hospital in London, and I'm going to be talking about ITP, the disease burden, treatment challenges, the pandemic, what we've been doing and what we will be doing when we come out of the pandemic. These are my disclosures. I'm going to talk very briefly about ITP, then touch on the pandemic. I'll have a look at the older treatments we have been using up until fairly recently, and then the prescribing during the pandemic. I'll focus in on second-line therapies, especially the thrombopoietin receptor agonists. Then I'll have a look at avatrombopag and the pivotal data for the newest thrombopoietin receptor agonist we have, and then look at other treatments briefly in development, and then look towards the future. So ITP, just in brief. ITP is an autoimmune disease. It's not terribly well understood, affects adults and children, although they are slightly different diseases in both adults and children. The platelet count is less than 100 usually, and some people have a tendency to bleed, can be bruising, petechiae, or very frank hemorrhage or intracerebral hemorrhage, which is the worst case scenario. But it's pretty benign. And the morbidity and mortality with ITP are low. People are not ill with ITP and they don't tend to die from ITP. Now, historically, we know that patients have more problems with the treatment we use than the disease itself. And I'm thinking about steroids and the immunosuppressives and other therapies. And we know that there's great patient dissatisfaction. This is from the IWISH study, which has been published extensively lately. But the introduction of the TPOs, of course, changed the whole ITP landscape. Now, we've gone through this pandemic. SARS-CoV-2, high mortality, high morbidity, major cost and disruption throughout the world. But it's not all bad news, because it has got some positive benefits. It has made us rethink how we manage ITP, because we have relied for a long time on immune suppression. It has made us rethink immunosuppression and what can we do to protect our patients. So because of the pandemic, we tried to avoid immune suppression where possible. We reduced the use of the older treatments. We did not prescribe much immunosuppression during the pandemic. We were also given in the United Kingdom approval for the early use of TPO receptor agonists from up front, in fact, which is off-label, but because of the pandemic, our government allowed very early use of TPO receptor agonists. Now, let me have a look at the older therapies. For many decades, we've used steroids, chemotherapy, androgens, we've used danazol, anti-D, rituximab. All of these drugs work to a certain extent, but they're not based on evidence. There are no good trial data for most of these therapies, unfortunately, but this is all we had until the TPOs were developed. So around the mid-2000s, we had eltrombopag and Romiplostim approved. And of course, these were very evidence-based therapies. The quality of life with these old treatments was not particularly good, and patients don't like them very much and they don't work very well, and there are lots of side effects with many of these drugs. But we knew for a long time that these old drugs were not the ideal therapy, but this is all we had. And the patients had lots of side effects, and they also didn't like the unpredictability of the old treatments because the efficacies are so variable. And there was already, before the pandemic, there was already a gradual decline in the use of the old treatments. The use of rituximab was diminishing. The use of the old immunosuppressants was already diminishing as the thrombopoietin receptor agonists became more popular. But the pandemic speeded up our transition from old treatments towards the new treatments. Suddenly we had to do this quite quickly because we had a virus which could be fatal, or at least could make patients very unwell if they were immunosuppressed. So looking at these old therapies, I will touch briefly on steroids, IVIG, immunosuppression, rituximab, and splenectomy, but this is only brief. I'm not going into great detail. Steroids are popular. They're popular because they're cheap, they're fast, most people respond. The problem is most people relapse when the steroids are stopped. They work within 1 to 2 days at 1 milligram per kilogram. This is prednisone. But the doses are too high, and the doses are given for too long. And so patients get lots of steroid-related unwanted effects. We use steroids in low dosing in two situations. One is the COVID-19 positive patient, and the other is in pregnancy. In COVID-19 positive ITP, we suggested in the British Journal of Haematology in 2020, try prednisolone or prednisone 20 milligrams a day, see what happens, wait a few days. If there's no response, increase the dose. Keep the course short. In pregnancy, for many years, we've used low-dose regimens, 20 milligrams a day, and we adjust the dose down to get the minimum effective dose. So prednisolone, prednisone, steroids, they work in the low-dose setting. So maybe we should be avoiding the 1 milligram per kilogram higher dose in all our patients. Start at 20 milligrams a day or 30 milligrams a day, see what happens. You can increase the dose after a few days, try to reduce after 2 weeks, make the course short. And I think this will give patients a much better quality of life with steroids. IVIG is highly effective. It's a very expensive therapy. It's a very inconvenient therapy. It works a bit faster than steroids, but it takes many hours to administer, and it's only really good for COVID-19 positive patients or as a rescue therapy or in pregnancy. Immunosuppression, there are many of these drugs around used in medicine generally and in ITP. I'm not going through all the side effects, but there are many side effects associated with these. The efficacy is incredibly variable, and the side effects outweigh any benefits. So they cause patients more harm than they do good. So they're not popular, and we don't like using them, and patients don't like receiving them. Rituximab, of course, we used for a long time before the TPOs were developed, but then we have to worry about vaccination. Patients will not respond to a COVID vaccine or any vaccine within 6 months of rituximab treatment. Rituximab, of course, predisposes to other infection because it's immunosuppressive, and it eliminates B cells for 6 months, 9 months. Over the last 2 years, 2.5 years, I think we've used very little rituximab, and I suspect the usage will remain fairly low from now on. Splenectomy has been used way back since the 1900s. It takes away the site of destruction and also probably the antibody production in many patients. The response rate is around 50 to 85%. But it's a major procedure, and it's removing a large part of the immune system, and it is associated with thromboses, with infection, and you have all the perioperative problems as well. So we try to avoid splenectomy where we can. So during the pandemic, in terms of our prescribing, we did not stop all the immunosuppression. If patients were on stable doses of immunosuppression, we left them on their drugs rather than try to stop them, because that would have caused them, many of them, to relapse, and they would have ended up coming to the hospital when we're trying to keep them out of the hospital. But very few patients were actually started on immunosuppression during the pandemic. So on the left, we have the older therapies, and on the right, we have the thrombopoietin receptor agonists. On the left, the immunosuppressants, the evidence base is very weak. They are slow to work. They predispose to infection. Many of them are teratogenic. The efficacy is very variable and not usually all that good, and not advisable during a pandemic or any time, but especially during a pandemic. On the right, the thrombopoietin receptor agonists have a very strong evidence base. They're fully approved for ITP. There's no degree of immunosuppression. The efficacy is very high, and they're preferable during a pandemic. So the usage of TPOs, eltrombopag, Romiplostim, has greatly increased during the pandemic. And avatrombopag, of course, which is now licensed in many countries. But the licenses vary between the molecules, and you have to learn what the licensing is for your own country. Most of our experience is in later ITP, not early ITP. So I'm talking persistent ITP and chronic ITP. But the data so far published, and Dave Kutter has published some nice data suggesting that they are just as effective if you use them early. And you may see more treatment-free remissions if you use them early. So as I mentioned earlier, in our country, we were given approval to use the TPOs upfront because of the pandemic, interim guidance. This is interim only during the pandemic. Now, the problem is they've just withdrawn this guidance for the UK, well, for England and Wales. So we are not allowed to use them very early anymore. This is really just to cover the period of the pandemic waves. So I don't know what will happen now. So let's have a look at second-line therapies, the TPOs, the drugs which have changed ITP beyond all recognition. We have three: two oral, eltrombopag, avatrombopag, and in the middle, Romiplostim is a subcutaneous injection. They all work incredibly well. They all stimulate the receptor. They all generate platelets, but the licenses do differ. So be careful when you prescribe and who you're prescribing for. I'll show you just a little bit of the old pivotal data for eltrombopag and for Romiplostim. The RAISE study for eltrombopag, the oral TPO, this is a 6-month study. The green circles are drug, the pink squares are placebo. The drug works during the 6 months of the trial, and then when the drug is withdrawn, the platelets drop back to baseline level again because the drugs are stopped abruptly. Bleeding for those on drug, again, the green circles, the bleeding diminishes during the 6 months, then returns to baseline when the drug is stopped. Those people who came in on background medication, maybe immunosuppression or steroid, 60% were able to stop if they were taking drug, but only 32% if they were taking placebo. So you can get rid of the older therapies, replacing it with a TPO receptor agonist. Romiplostim, a very similar study, again, 6 months. These are both 6 months. This is splenectomized. These are non-splenectomized. Patients on drug, the solid squares respond. Those in placebo, the triangles don't respond. And again, at the end of the study, when the drug is stopped, the platelets go back to baseline. So overall, from those older TPOs, we know the efficacy is very high, 80% or more, well tolerated, platelet counts rise beautifully, bleeding, if there is any, diminishes and goes away, quality of life is good. And patients, this is based on surveys, patients and doctors prefer oral therapies to other routes of administration. So let's have a look at avatrombopag, which is the latest of the thrombopoietin receptor agonists. It's a small molecule. It has 6 rings. You can see it here. I have an animation here showing the molecule rotating. 6 rings, whereas eltrombopag has 4 rings, but they're both small molecules. Native TPO, which is up here, top left, this large grape-like thing, binds to the TPO receptor at the extracellular domain, stimulates this pathway and generates platelets. Romiplostim binds to the same site as native TPO, but the small molecules, eltrombopag, avatrombopag, bind to the transmembrane domain. But they all stimulate the same pathway. They all generate platelets. So the randomized studies for avatrombopag, there are 2 main studies. One is the phase 2, which is the dose-finding study, and phase 3 is equivalent to the 6-month RAISE study done for eltrombopag. So I'll focus mainly on the phase 3, which is a 6-month study, double-blind, randomized, 49 patients. Looking at the efficacy of avatrombopag in the 49 patients with chronic ITP from 12 months onwards, adults, stratified exactly the same as eltrombopag into splenectomy status, platelet count, and background medication. And the primary endpoint was the number of weeks with platelets of 50 or greater without the use of rescue therapy. I'm going to skip over the inclusion and exclusion because they're very standard. So here are the endpoints: primary, secondary, and additional. Primary is the number of weeks with a platelet response. Secondary is the platelet response at day 8. And then the additional endpoints were the durability of the platelet responses. And here are the phases of the study: a titration phase to get the dose right, and then background medication would be reduced and hopefully stopped, and then a maintenance period following that. And you can see the platelet counts for those on drug in the orange circle. Placebo never reached the target of 50. So the drug clearly works, and this looks very similar to eltrombopag and very similar to Romiplostim. The primary endpoint, the number of weeks with a platelet response, platelets of 50,000 or more. Here is drug, which is very dramatic, 12.4 weeks, 0 for placebo. Look at the p-value, p less than 0.0001, very significant. Durability, 34% on drug, 0 on placebo. Adverse events. I don't want to go into these in detail because there's really nothing much to say, because placebo and drug really not a great difference. What I would like to show you is the liver function testing. Liver function tests, you will remember with eltrombopag, can be disturbed with a rise in ALT and AST and bilirubin, but for avatrombopag, there's no disturbance of liver function at all, the same as placebo, 0, 0. The long-term extension study looks like the eltrombopag long-term extension study. Patients keep responding and there are no new safety signals. This is from a multi-center American study looking at switching and duration of treatment. 45 patients, they switched from Romiplostim or eltrombopag to avatrombopag because either it was more convenient or these drugs didn't work or there were adverse events. The median dose was 140 milligrams per week, which is 20 milligrams per day. And these are the platelet responses. This is Romiplostim eltrombopag is kind of okay, but much better with avatrombopag. And these are the median platelet counts, again, much better with avatrombopag than the patients were with the Romiplostim or eltrombopag. And this is treatment length, which I don't think really matters. So from this little mini study, it was evaluated in the real world in patients switching from either Romiplostim, eltrombopag to avatrombopag. The median platelet count increased significantly. I showed you that graph. Once they switched from the older TPOs to avatrombopag, more than 90% achieved a platelet count of 50 or more, 16% discontinued, which is a small percentage because of adverse events or it didn't work. And the length of therapy and persistence was the highest with avatrombopag. Now, just comparing the three together, Romiplostim, eltrombopag, avatrombopag, the advantages on the left, the disadvantages on the right. The advantages of Romiplostim is it's only once a week and lots of scope for titration. But the problem is it's an injection and there are many, many doses and there are platelet fluctuations and training has to be done and many hospital visits. Eltrombopag is better, only 3 doses, taken by mouth. Patients don't require training, but there are dietary restrictions. There are compliance issues, liver function disturbance, and you have to reduce the dose in East Asians. Avatrombopag has even more benefits. It's oral, it's convenient. There are no dietary restrictions. There's no liver function disturbance. There's no need to reduce in East Asians. You don't have to come to hospital. And the only downside is really, I think, that it's for chronic ITP only from 12 months onwards. I'll just touch briefly on the sustained responses that we see now with patients who have TPO receptor agonists for 6 months or more, who are able to taper and come off drugs completely. 1/3 with Romiplostim, 1/3 with eltrombopag, and I suspect it'll be 1/3 with avatrombopag. It's a class effect. The TPO receptor agonists in general, 1/3 of patients on a TPO can expect to come off the drug and remain well on no treatment. We should be using these drugs much earlier, but we have to bear in mind the label and the license for every country, because we have ITP, we have newly diagnosed where we've been using them, but we're not allowed to here anymore. We've got to wait for at least 6 months, if not 12 months, to use these drugs now. But these phases are arbitrary, and the guidelines, the consensus guideline, the American guideline, the German guideline, we all advocate early use. If you're allowed to use it early, you should use it early. This is just briefly Dave Kuta's data showing Romiplostim in patients with ITP for less than a year compared to more than a year. And they had 300 patients with ITP less than a year and 700 or more than a year. And just to show you the data, the responses are very similar between young or recently diagnosed ITP and ITP that has been around for years. And those discontinuing was slightly higher in the patients who had ITP less than a year and given a TPO, as opposed to those with ITP more than a year. It was a lower number. So you may see more of these treatment-free remissions if you use it early. We do need other types of therapy, though. TPO receptor agonists are amazing, but we do need additional classes of therapy. And so proved on the left, we have TPOs. We also have fostamatinib, of course, a SYK inhibitor. Those are the only approved therapies worldwide. On the right, we have the drugs going through clinical development, the anti-neonatal Fc receptor, Bruton tyrosine kinase inhibitors, complement inhibitors, and other molecules. These are in trial phase and will be available over the next few years. So what do we do now? What do we do now? The pandemic is fading away, we hope. Do we want to go back to the old model of treatment, the 2019 model? I think our patients are very unlikely to want this. And I think most doctors will not want to go back to immune suppression, splenectomy, all that kind of stuff. But can we afford it? And of course, money is a big problem in many countries. Can we afford the COVID model? So the options, I think, the pros on the left and the disadvantages on the right. So looking at the left, the advantages of using predominantly TPOs, they're quick. They're very, very high efficacy. You've got the possibility of these treatment-free remissions. You can stop or at least reduce background immunosuppression, and the quality of life is good if you use a TPO type model of therapy. The problem is on the right, they don't work instantly. You have to wait 7 days for a response. So you probably need something else with, say, avatrombopag, like some steroid, a short course of steroid. Some of the TPOs need training, like Romiplostim, and then there's the cost. They are expensive therapies. So this is something we need to think about as we come out of the pandemic. So I think what is likely to happen is that we will continue to use a lot of TPO, and we should be using all three. If you fail one, try the other. If you fail that one, try the third. If you fail all of them, then maybe fostamatinib. We will use steroids, but try to keep the course short and a low dose. We're waiting for the new classes of therapy, of course, for the patients who fail TPOs. If the budget allows, we will use little immunosuppression. The guidelines will certainly need an early update. They were published in 2019. We can't wait 10 years. We'll have to do it within the next year, I think. So COVID has had a major worldwide impact, but there have been some positive benefits. It's really made us think about how we manage ITP. There had been a gradual move away from immunosuppression anyway, but the pandemic speeded up our transition towards non-immunosuppressive therapies like the thrombopoietin receptor agonists. And the TPO receptor agonists are likely to remain the dominant therapy, but other drugs will be coming in the next few years. And avatrombopag, as the latest in the line of TPO receptor agonists, as you can see from the data, is very effective. It's oral, there are no dietary restrictions, there's no dose reduction, and it looks very, very promising. So with that, I will thank you for your attention. Thank you very much.